Good afternoon, and thank you for joining us today in this image challenge live stream event from Retinal Physician. My name is Marianeli Rodriguez, and I'll be your host today. I am a retina specialist with Vitreoretinal Associates, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We would love to hear your thoughts online. You can find us on Facebook, LinkedIn, YouTube, or Twitter, and also in Instagram. You're also welcome to write on the chat and share your thoughts with us during this event. Today, we will be discussing the case of a 78-year-old gentleman who was referred to us for possible management of a retinal detachment. He was complaining of floaters for a few days, and he denied any pain or photophobia. His visual acuity in the right eye was 20/40, and he had normal intraocular pressures. The anterior segment was significant for 2+ cell and keratic precipitates in the cornea. He also had significant 2+ vitreous cell. On fundus examination, a large patch of retinal whitening was noted inferotemporally with multiple white satellite lesions in the periphery. At this time, we had a high suspicion for acute retinal necrosis, and upon further questioning, the patient endorsed a recent episode of herpes zoster virus. He did not have any active skin lesions at that time on examination. As you know, this is a condition that we rarely see in our private practice, so we did not carry any antivirals that were needed to treat this patient. Therefore, we sent him to the eye emergency room in Boston for anterior chamber paracentesis and to obtain a definitive diagnosis, as well as for the injection of intravitreal antivirals as needed. So, acute retinal necrosis, also known as ARN, may present as panuveitis. The principal viral agents that cause this disease are VZV, HSV1, and HSV2. The disease is thought to have two phases. The first one is the acute herpetic phase with panuveitis or optic neuropathy, and then the second one is the cicatricial phase, where breaks can occur over the atrophic retina that is thin, leading to retinal detachments. In terms of treatment, most uveitis specialists advocate for local and systemic treatment. Intravitreal injections of ganciclovir and or foscarnet are recommended. Systemic oral therapy with valacyclovir, acyclovir, or ganciclovir are also recommended. And steroids may have some beneficial therapeutic effects after the start of antiviral treatment. And then once the regression of the retinal necrosis is demonstrated, this steroids can be started. So there is no consensus on whether laser demarcation of the areas of necrosis is beneficial in preventing retinal detachments after the above treatment is initiated. So we usually do not do that. The visual outcomes for eyes with ARN is variable, and a lot of it depends on the extent of the necrosis at the time of the presentation. So thank you for tuning in today. I hope you learned something from this presentation. You can leave us comments online via our multiple platforms, and we hope to see you again in about a month as we discuss another interesting case. Thank you.